I'm Kathryn Pagliaroli. I'm the Director of Quality and Patient Safety here at Oswego Hospital, and I've been doing that for 3 years now. I oversee the actual quality function of the hospital, which is ensuring the quality requirements are met. I also oversee programs such as clinical documentation improvement, case management, and care transitions. The connection between the early epidemiology and the work that we do here is really centered around the idea of we have some things we know and some things that are still unknown, but we treat and we practice as though they're real. So John Snow thought that it was around water pumps at that time, and so that's where they centered their efforts. So for example, things like Ebola, we know that that's transmitted through animals, but we don't know exactly who the host is for that. So we practice and we train as though it's transmitted through animals, although we don't have the firm science to prove it. So we take information that we get from a variety of sources, the CDC, what's going on through the state communication lines for things such as Ebola, Zika, flu. We get data in talking about really the structure of what we should be expecting or what we could expect to see, and then we start to prepare. Hand washing is our #1 way to prevent the source of infection and the spread of infection, and so that is one thing that we do continual training on. We do monitors, we do education every month. We talk to everyone about hand washing. We have a priority system in place, so anybody can speak up about hand washing. It doesn't matter if it's the environmental services worker asking the physician or vice versa. We have an antibiogram that we produce through our lab, so all the testing that we do towards susceptibility and resistance in our lab and the cultures that come in and the antibiotics that we prescribe, we correlate all that data, and we can see resistance patterns developing based on antibiotic usage. And so we've given that data historically to inpatient physicians to help them in their prescribing practices. And recently we had some outpatient physicians asking us, could you do the same thing for us? The light bulb went off, of course. So now we can give an outpatient rate. For example, in the hospital we were seeing an increased resistance to Levaquin, little overuse of Levaquin. So we started to reduce our use of Levaquin. We saw that susceptibility come back. Same thing in the outpatient setting. You can look at specific, antibiotics and say, where are we with resistance, susceptibility? And now we've gone on further and done that for the local area nursing facilities. So the nursing homes can kind of get in on that data too. What are they prescribing? What are we seeing as a community that's maybe a resistance pattern? And really trying to, we call it stewardship, use our antibiotics appropriately so that we keep that susceptibility margin. One of the things that we're seeing is, across the communities, community-acquired MRSA. And when a patient comes in, traditionally with any history of MRSA, we would immediately put that patient on isolation precautions and really make sure that we were ensuring that that wasn't going to spread throughout our hospital community or more throughout our community. It's the best field ever. It's never dull. So every day there's a new challenge or a new success story that you got to be a part of, and you get to celebrate when we have good hand washing rates. It's not because I did a good job or because our infection preventionist did a good job. It's because every person who walked through that door washed their hands. And so you get to celebrate successes all along the way. So it's energizing because you're making a difference in people's lives. And then as you see populations change and you see areas that you want to improve, healthcare providers tend to be competitive. So we want to do well. We want to keep pushing the mark. And so it's a rewarding, enriching. I think it's fun. Some people probably think that's crazy, but it's fun.